Welcome to week 8. So our Thursday lecture was rescheduled, really canceled. I did record those chapters. We did 25, 27, and 26. So that was posted last night. If you haven't had time to watch it yet, that's okay. That was just the first time my voice was cooperating long enough to record a lecture. I will work on those end of chapter questions today, and quiz number 4 will probably be posted Thursday or Friday. I haven't made it yet. It depends on how much we can get through today, so that you're quizzed on everything. Does anyone have questions before we start with the new material for today?
Not yet.
Not yet. All right. Now, if y'all are watching that lecture and you're like, this makes no sense to me, by all means, please email me. I'm happy to answer any questions you have. You are never bothering me. You never have to apologize for emailing me. That's what I'm here for. That's my job. So just let me know whatever y'all need, and I will do my best to make it happen. Plan for today is to go over this PowerPoint to do a case study together on dentalcare.com. Have y'all signed up for dentalcare.com yet? Yes, perfect. Have you done any case studies there yet? Uh-oh, all right. We might have to switch our plans up a little bit if you've already done this case study. And then last but not least, I would like to review exam number 3 with everyone. I will be turning off the recording for that part so that the test answers are not available out on the internet, but I at least want y'all to have a chance to go over those. So let's go ahead and start with acute periodontal conditions. What does acute mean? Y'all already know this part.
Short.
Short, okay. Kind of like rapid onset, right? So what is the opposite of acute?
Chronic.
Chronic, and chronic means? Long, slow process. So acute is short and quick. Think about like a leprechaun, a cute leprechaun, short and quick. They run away. Come on, then. All right, here are your objectives from the syllabus. And here's what we're going to go over today. There are a few different things that we'll cover for acute conditions. These can also be defined as emergency conditions. And the reason we cover them in perio is because you and I might be the first person to see a patient with this condition. They also go to the emergency department quite frequently. And I don't know if y'all have learned about emergency departments and how overloaded they are, not just because of COVID, but in general. And then you add on patients who have, problems with their teeth. Are most emergency departments equipped to handle that? No. You're lucky if they have one dental chair, and even if they have a dentist on staff. Usually that's not the case. So a lot of these things we may see, if the doctor puts an emergency appointment on your book because they're full, just to, get the patient in that day because they're in pain. Different things to look at and to think about. So we always want to address the patient's chief complaint. And in this chapter, it's talking specifically about pain or discomfort. And the reason we have to understand this as an RDH is that we have to recognize, manage, and treat acute periodontal conditions. And in Tennessee, we've recently gained the ability to prescribe medications. So that also goes into these acute processes where we may need to prescribe something for our patient. We can also offer suggestions for management of the conditions. So anything to do with the periodontium, of course, that is our wheelhouse. That's what you and I are focused on. Now, most periodontal diseases are chronic, episodic, painless processes, which is, the patient thinks it's great because they're not in any pain. What is the downside to it being painless?
You don't advance too far.
It advances and the patient doesn't seek treatment, right? So we've got all kinds of issues with this. If you've ever listened to Claire from Student RDH speak, this is where she says, Mother Nature really screwed up, not making periodontitis painful. If it was painful, more people would get preventive care instead of restorative care. So these are pretty rare cases. You're not going to see a lot of this, but again, these are emergency situations. And they, again, have a sudden onset and rapid course of progression. So what's an example here that you can think of off the top of your head, an acute periodontal condition?
Gingivitis.
Okay, what kind of gingivitis? Because there's plaque induced, right? That would be like a slower process, a chronic process. What kind of, you're right about gingivitis, but specifically a kind caused by bacteria, specific bacteria. What's a type of periodontal disease that comes on very suddenly? Y'all know this. Trench mouth.
Nug.
Nug, good. Necrotizing gingivitis would definitely be an acute periodontal condition. So here are the common characteristics. Again, we've already talked about this: pain, discomfort. We can also see systemic manifestations. When we talk about systemic manifestations, can you think of anything that would start in the mouth, an acute process that starts in the mouth and may spread systemically?
Infection.
Okay, infection, a bacterial infection. How about viral? Can you think of something viral in or on the mouth that can spread?
Herpes.
HSV1. We can spread HSV components from a vesicle to other areas of the face. This is why we want to get this under control right away. Early recognition is imperative. We always have to make sure that we are listing an appropriate lesion description. What's our time frame? Let's say you're working in the office and the dentist is on vacation. Patient presents with a lesion. When would you tell them to come back if it hasn't resolved?
As soon as the dentist is in office.
Okay. What if it's something and you're like, I'm pretty sure it's not a big deal? What would you say about it?
Maybe a week.
A week? It's usually 2 weeks, because depending on the depth of an injury like trauma or a burn, it may take 2 weeks for it to heal completely. So if that lesion is still present after 2 weeks, we'd want them to see the dentist or get a biopsy. So let's talk about abscesses. Which kind of abscesses do you already know about?
Periapical.
Okay, periapical abscess. And that's a result of what?
Infection.
Infection of?
I'm gonna say periodontal, where I know it's where the infection gets into the pulp.
The
right?
pulp, good. Yes, infection of the pulp. That's a periapical abscess. And you would find it at the apex of a tooth. So this is the most common kind of, abscess that you're going to see. Now, when we talk about other abscesses of the periodontium, they can appear very different in the mouth and on a radiograph. So this is an acute infection with a circumscribed collection of pus. What does this word mean, circumscribed?
Around.
It's usually like round and well-defined. We can see it. Collection of pus localized within the gingival wall of a pocket. So this is a really great picture from your textbook. It's hard to get a picture of these because they're not very common. Y'all know what pus is if you've ever had a pimple or watched Dr. Pimple Popper. Pus is exudate that is mostly dead or dying neutrophils, bacteria, debris, and fluid leaked from the bloodstream. It's also known as purulence, but here we're just going to say pus. And usually what we find if we were to send this to microbiological testing, would be a lot of gram-negative anaerobic bacteria. So this is where, did y'all in microbiology, did you get to swab your mouth and then culture it? Have you ever done that before? It's really cool if you can. I definitely recommend trying it. When I was in school, we went to different areas of the school and swabbed an item, and then we we were able to culture it and grow it over a couple of days. You would not believe the things they found on the public surfaces, on the couch, on the toilet seats, on the drinking fountains. One person was growing gonorrhea in their thing, like just from swabbing different areas. Yeah, it's disgusting. So this, if you were to swab this and take a culture, we would see gram-negative anaerobes. The characteristics, of course, pain. This isn't supposed to be here. Look at how large that papilla is. Of course, that's going to be painful. There's extra fluid in there. If you've ever gotten a bump or, even a pimple sometimes can be uncomfortable because it's full of fluid that shouldn't be there. It's a constant localized pain. Now, this is for an acute abscess. If an abscess is chronic, remember it starts to lose that pain response and it starts to get more pink instead of red. All of those things we've talked about in the differences of acute and chronic inflammation. The patient may have difficulty chewing because they're in pain. There's a localized swelling. There might be a bad taste in the mouth. What is that bad taste?
Exudate.
Exudate, it's pus. They're tasting the pus. Of course it tastes bad. Ick. There's an increase in mobility, a potential for that based on how large the abscess is. It could actually be displacing the tooth. Radiographic bone loss. This will not usually be at the apex for a periodontal abscess, and it progresses much more rapidly
Hey, Miss
than.
Mitchell. So I think you've already answered this before but I'm going to ask again because I don't remember what you said.
That's
What
okay.
happens if like, so I know some people that have had abscesses before on permanent teeth, and what is wrong with them popping it at home? Because I know some people have done that.
While popping it at home, it can leave a entry point for bacteria into the tissue. And it's not fixing the problem. Draining the abscess is just like a Band-Aid. They still need an antibiotic and root canal therapy or an extraction, depending on how severe the abscess is. And depending on the socioeconomic area that you're working in, patients can't afford root canal therapy and a crown. They may just get it extracted. So it's a temporary fix, aimed at relieving the discomfort from the pressure of the pus buildup. Does that answer your question? And then you'll notice later it just fills up again. So it didn't fix it, it just kind of put a Band-Aid over it. That's a great question. Now, most teeth with periodontal abscesses have a vital pulp. So how do you and I know if a patient has a periodontal abscess? What might we see clinically? Swelling. When you probe, what might happen?
Bleeding.
Exudate and bleeding. It'll be kind of like a milky yellow blood mixture coming out of the pocket. So that's definitely something we have to list on our periodontal chart, that we're seeing suppuration or pus. Excuse me. All right, so what causes this? We either have a blockage of the opening of a periodontal pocket. If the tissue is keratinized and extra firm, who would we see this in?
Tobacco users.
Yep. Tobacco users. So they could have a periodontal abscess and not even know. Okay. The next one is forcing a foreign object into the tissue, and it actually allows bacteria to enter the tissue. It's making a little ulceration and bacteria can get in. This can happen with a toothpick. This can happen with food, like with a popcorn kernel. One thing I saw a lot when I was in practice was the skin of almonds or peanuts really gets embedded into the sulci. So something to watch out for as you're seeing patients. And then incomplete removal of calculus. This is really important for you and I to know about because it is our job to completely remove a calculus deposit in order for the patient to heal. What is calculus always covered in?
Biofilm.
Good, plaque biofilm. So can we get formation of a long junctional epithelium if there's calculus residing in the pocket? So this is what happens when calculus deposits are removed supragingivally and not subgingivally. And when we talked about treatment plans last week, we mentioned that there's a code for a gross debridement. I can't remember the code. Does anyone know the code number?
4320.
Something like that. Yeah, good enough. Okay. So I never, ever, ever, ever want y'all to do these because this has a high potential for creating a lot of issues in the mouth. If we remove supragingival calculus on a patient who has subgingival calculus all over the mouth, the tissue, specifically the gingival margin, is it's like tightening it, right? When you tighten your scrubs, it cinches your waistband. That's what's happening with the gingival margin. It's tightening around the tooth, but subgingivally, all that bacteria is still active. We're not getting any healing of the periodontal pocket. It's actually getting worse. So can you imagine having a patient who has subgingival calculus, let's say a calculus 4, but they have super tight gingival margins on all of their teeth? Is it going to be very comfortable for you to have to dig? Nope. So that's something I never want y'all to do. Now, I say that if you have to debride one tooth to plate, to allow the dentist to place an occlusal, composite, that's different. But I never want y'all to remove all of the supracalculus and leave the sub. That's just a bad idea.
Ms. Mitchell,
Mm-hmm.
is this gross debridement the same as a 4355, which is a debridement?
Yes.
So what if
It is.
Okay, so my question is, what if the doctors are wanting you to debride because of the fact is that there's so much calculus you can't do a probing on it?
Now, even if you remove supracalculus, you're still not getting appropriate probing depths due to the subgingival calculus. So what I do in that situation is complete the scaling of the entire quad and then complete my perio chart to submit to insurance. Because even if you probe at that point, you're still not going to get accurate probing depths from all the subgingival calculus. Does that make sense?
Yeah, because I think some of them, they usually, like our doctor, he would always say, well, to the hygienist to go ahead and debride them and then bring them back for the SRP. So that way you can go ahead and do the perio charting.
Right. But it doesn't allow for accurate perio charting. And we see lowered compliance with patients coming back because they think, well, they cleaned my teeth. Why would I need to go back now? It looks better. So I stopped doing those. And that's just part of my personal practice. I will not do a gross debridement. Now, it's important to note gross debridement is different than debridement, than periodontal debridement. Periodontal debridement doesn't get its own code. There's no code for periodontal debridement. It's just a description of what you and I are doing during a cleaning. Callie, I saw you say, oh, were some of you wondering that? Yeah, so periodontal debridement only means that we're removing deposit from the tooth surfaces, from all surfaces. Whereas a gross debridement is removal of only supragingival calculus. If a doctor wants to do that, I tell them they are welcome to, but then I won't do it because it violates my personal, opinions and my ethics. And usually they scoff at me and then walk away because they know it's not right. They just want to bill it out because it's an expensive code. Or maybe they don't know it's not right and we can explain it to them. All right, so what's the difference between a periodontal abscess and a pulpal abscess? Sometimes, depending on the location, it can be really hard to tell, but a pulpal abscess is almost always at the apex of a tooth, and it's caused by necrosis or death of the pulp. A lot of times we see this with trauma. Have y'all ever seen kiddos who hit their front teeth on something and then the tooth dies and they get an abscess, right? We got to pull those teeth. Sometimes we see deep dental decay that hasn't been taken care of for a long time. And this either requires a root canal or extraction. So root canal therapy is where they remove the pulp and replace it with a material. What's a common material we see for root canals?
Is it gutta percha?
Gutta percha, nice. So a little bit of dental materials review for you. Now, we should see, resolution. But a lot of times with root canal therapy, we end up having to retreat down the road. And now we're leaning more toward implant placement than root canal and crown therapy. It's more expensive, but it also should last for the life of the patient. So here are some different ways we can tell whether a patient has a periodontal abscess or a pulpal abscess. Have y'all done the vitality tester? Do you have one of those, the pen, where you can send a little shock and the patient knows that that's a vital tooth? We can also use endo ice. Have y'all used that before, endo ice? It's kind of cool. They have it in offices. You can just put it on a cotton tip applicator and touch it to the tooth. You can also just tap on the tooth, percussion. If the patient skyrockets out of their seat, that's probably a periodontal abscess versus a pulpal abscess should be non-vital. Radiographic appearance, again, is it at the apex or is it along the PDL somewhere? And then symptoms. It's really difficult to tell based on symptoms. We have to use these other things along with it. So how do we classify an abscess of the periodontium? It's either acute or chronic. And y'all already told me the difference between acute and chronic. So an acute abscess is symptomatic, it causes pain. A chronic abscess is usually one like Faith was talking about, where patients can express the pus and it relieves the pressure. But then again, it comes back later. A gingival abscess is exactly what it sounds like. It is limited to gingival tissue, either the margin or the interdental papilla, no involvement of deeper structures. Just from looking at that, you can tell something's wrong. Yeah? I hope. How would you describe this gingiva?
Edematous.
Edematous, good. What's the color?
Erythema.
Erythematous, good. So we definitely have some issues going on here. It's probably going to bleed pretty easily, but it's important to note that a gingival abscess is usually on a previously healthy mouth and a response to some sort of foreign object forced into the sulcus. So we don't see a gingival abscess a lot of times on, sorry, they're vacuuming. I don't know if y'all can hear that. Still in a hotel, yay. This is a previously healthy mouth that has, a popcorn kernel. What are some other things you can think of that would get forced into a sulcus and cause an issue?
Chips.
Chips, tortilla chips, Doritos, what else? as I'm watching y'all chew away on your pens.
Our pencils.
Yep. What else?
The skin of apples.
Yeah, the skin of apples. That's a good one. Steak, right? Meat can get really forced down into the sulci. How often are patients flossing?
Not very often.
Not enough, right? Never enough. So this usually happens if something's been forced. The other thing I want to point out is if we broke an instrument tip and left it in a sulcus, purposely or accidentally, right? So this is, again, a little plug for instrument maintenance, right? Sharpening your instruments, checking the integrity, looking at your instrument cassette after you finish a patient to make sure there are no broken tips. Now, a periodontal abscess. This is involving deeper structures of the periodontium. This is where we start to see issues in previously existing periodontal pockets. So the pocket was there, the bacteria was opportunistic enough to create an abscess. And here you'll see it's kind of difficult to tell on the radiograph, but I'm going to zoom in a little bit. When you look here on the picture, and then you look at the radiograph, where do you feel this periodontal abscess is located?
Number 31.
Okay, number 31, and you can kind of see this radiolucent area all through here. So it would correspond to the distal. Do you see the widening of the PDL there? That indicates that there's something wrong, infection or trauma. And then I want to point to this area of the furcation has some bone still, but then we see this radiolucent bit, right? So that is where the periodontal abscess is located. I saw this one time. The whole time I've been practicing and in school, I have seen one periodontal abscess, and I had to try really hard not to geek out as the perio and radiology teacher in front of the patient. We ended up having to turn him away because of the severity of his periodontitis, but he had a few periodontal abscesses. So just something to look for. And then, you know, conversely, you would see a periapical abscess at the apex of a tooth. Now, paracoronal, you will see these. You'll see these quite often. What does peri mean?
Around.
Around. Coronal.
Crown.
Around the crown. An abscess around the crown. So this is usually on a partially erupted tooth. We see soft tissue inflammation, and they usually cover the occlusal surface of the tooth, at least a portion of it. Most frequently, these are found around mandibular third molars due to incomplete eruption. And an operculum, this is a word that's going to come in handy throughout your practice. An operculum is the flap of gingival tissue that's covering that occlusal surface. So this is what it looks like. And it's going to be pretty painful. The patient may not be able to eat. If you ever see an operculum, what do you think you could recommend for home use to keep this area clean until the patient could have it extracted?
A water syringe.
Good, like a monojet syringe with water or mouthwash in it, perfect. Now this one specifically is infected and we can see the pus. So that would be pretty painful for the patient. This is one of the reasons we recommend third molar extraction. Some people, for cultural reasons, personal reasons, don't want to have their wisdom teeth removed, and that's okay. But you and I have to know how to educate them on cleaning these areas. When I was, sure, hit me.
This is kind of off topic, but it's referring to third molars. My friend had her wisdom teeth extracted about a year ago, but her wisdom teeth were pretty much like fully in. and
Mhm.
she still has pain with it sometimes and has like a little hole. Like, what would that be?
I don't want to get too far into like her personal business, but does she smoke or did she have a dry socket, anything like that?
I don't think so.
It could just be an alveolar ridge defect that she might need to see the surgeon about and, get a bone graft or something to like refill that area to help her. Yeah, she might have to go get it checked. The other thing is, how close were the roots to the mandibular canal when they removed them? Is it like pain inside her mouth or is she feeling it on her face? It kind of depends on the positioning. Because like here, you can see the mandibular canal. If they remove that wisdom tooth, it could, interfere with the inferior alveolar nerve. Yeah, just depends. But there are a lot of reasons we recommend patients have their wisdom teeth extracted, and this is one of them. You can actually see the soft tissue coverage, the operculum, right over that. Now, signs and symptoms, patients usually complain of pain, and it is painful. I mean, it's in your oral cavity. Swelling, erythema, trismus, they may not be able to open their mouth all of the way because of the pain. They may have a body temperature, possible lymphadenopathy. If they have one of these symptoms, what are we recommending for them?
Tylenol.
Okay.
Antibiotic.
Antibiotics, Tylenol, what kind of antibiotics? Systemic or topical?
Systemic.
Systemic. We have systemic involvement at this point, so they will probably require a systemic antibiotic. Very good. Tylenol is great for pain. A lot of times when we have abscesses, NSAIDs work better because they're anti-inflammatory versus Tylenol. Aspirin's another one, but I don't usually recommend aspirin. I stick with the NSAIDs like ibuprofen unless the patient's allergic, in which case Tylenol would be the drug of choice. All
And
right, how do we, oh, go ahead.
What would you do? Like, so for pediatric, when they get abscesses, my doctor always gives them amoxicillin or penicillin.
Mhm.
So when would you recommend that? Is that just something the doctor would say?
Yeah, it's up to the doctor which antibiotic they want to recommend, but anytime there's a periapical abscess, which I'm guessing is what you see from deep decay in pedo, they would need an antibiotic to get that under control and then treatment of the tooth. Does he usually extract or what does he do? Yeah, antibiotic and then extraction for a primary tooth is very common because if we don't take care of that infection, it can actually infect the permanent tooth. And then think of how small kids are. If they have an infection on a maxillary molar, how close is that pocket of infection to the brain? It's very close and it can spread to the brain. We actually do see this cavernous sinus infections, and we've actually seen children die from decay because it wasn't taken care of. So this is why when parents say, why do I need to treat a baby tooth? This is why. Infection is not healthy for the body. So how do we treat this? A periodontal abscess. We have to establish a path of drainage. Where is it coming from? What is happening? How did this get started? Then we debride the area. It's going to take anesthetic. It's going to take, probably some chlorhexidine afterward, and then control the discomfort and the pain either with NSAIDs or Tylenol, some sort of over-the-counter pain relief. Now, do y'all remember from pharmacology, why do we recommend something over the counter like Tylenol or ibuprofen rather than writing a prescription for an opioid?
Because the NSAID goes to the infection, gets rid of
Okay.
the.
How does it relieve pain? How does an NSAID relieve pain?
It takes care of the inflammation.
Exactly. And they're experiencing pain from that inflammation, from that fluid-filled sensation. Opioids, they're overprescribed, they're highly addictive, and they actually don't take care of dental pain as adequately as NSAIDs and or Tylenol does. So another thing to explain to your patient if they have an abscess. We have to anesthetize the area, drain the pus. Usually the doctor will drain the pus because they will have to make a tiny incision. We have to debride the area, adjust the occlusion if it's super erupted due to an abscess, prescribe antibiotics if they're needed. And again, you know, I think it's going to take a while in Tennessee, but eventually y'all will be able to prescribe your own antibiotics. Your doctor will trust you to do that. Warm saline rinses. What's saline?
Distilled water.
It's salt water. Saline. Have you ever gone to the hospital and seen a charge for $200 for a bag of saline? They charge you $200 for salt water. So another issue with our hospital system. Prescribe pain medications if necessary. What do you think would be a good prescription medication to use in this case?
Will it be amoxicillin?
Well, amoxicillin is a prescription antibiotic, yes. But for pain, what would we recommend?
NSAID.
NSAID, so like 800 milligram ibuprofen tablets. Potentially Tylenol 3, depending on the level of pain, Tylenol with codeine. But we're trying to stay away from those opioids. So 800 milligram ibuprofen. Have y'all ever read the studies explaining that alternating 400 milligrams of ibuprofen and 600 of Tylenol every 4 hours takes care of dental pain more effectively than opioids like Vicodin? So when your patients say, I need a prescription, it's not going to help. Alternating Tylenol and ibuprofen is much better for the patient.
Did you say 400 milligrams of, what was it?
Yep, it's 400 ibuprofen and 600 Tylenol.
Thank you.
I can send y'all some research too on that if you'd like to see it. I'm happy to share it. It's actually really cool to see. All right, management of pericoronal abscess. Usually we have to irrigate the operculum. This is very uncomfortable and it really smells very bad. If you've ever irrigated an operculum, it's kind of stinky. The patient will probably have a bad taste in their mouth because food gets trapped in it and rots there. There's lots of plaque biofilm, pus, all kinds of things in that nasty little pocket. Then we instrument and relieve the pain. What's the easiest way to remove an operculum?
Would it be like a laser?
Laser that bad boy off. When I was 12 years old and got braces, I had operculums on my terminal molars. This is a fun story, 18 and 31. They literally stayed over their break and the ortho assistants amputated my operculums and forced the metal bands down around my teeth. And I was just crying. I was, in pain, trying to stay still. So don't do that to your patients. It was traumatizing.
The ortho assistants are allowed to do that?
Nope, but they did it.
Did they not know? Were you not numbed or anything? Topical?
Nothing. They just kept trying to force the band on and they couldn't get it. So they cut it right off. It was awful. It was awful. So the laser automatically cauterizes the wound. It heals a lot faster. It's easier for the patient. And you can just use local anesthesia. Here's a great example of an operculum with a pericoronal abscess. You can see all the space between the tooth and the wall of that abscess. And that's just packing food and plaque and all kinds of stuff down in there. So of course it smells bad. It's gross. Have y'all ever seen one of these or had one of these? You will. You will see it. It's very common on like 17, 18-year-olds with partially erupted third molars. This is usually why we send them to oral surgery around that time. All right, the big guns now, necrotizing periodontal diseases. Y'all already know about these. These are the most severe biofilm-related periodontal conditions. There's destruction and death of the tissue, also known as necrosis. And sometimes we see a diminished systemic resistance to bacterial infection. That's just a fancy way of saying that the patient has a poor host response to bacteria, specifically the bacteria involved in necrotizing diseases. The hallmark of necrotizing diseases is cell death, necrosis. We also see impaired host response. These are some of the contributing factors: poor nutrition, fatigue, psychosocial factors like stress. Who did we say this is usually prevalent in, these top symptoms here? And maybe alcohol and drug abuse too.
College students.
College age students. So when y'all are looking at case studies, these may be some of the keys, you know, some of the clues to your answers, that this is a necrotizing periodontal process rather than a chronic or, you know, normal periodontal process. Signs and symptoms. We see spirochetes and bacilli bacteria present. Usually this is around 20 years old. Now, the punched out papilla, the pseudomembrane, spontaneous bleeding, and fetid odor. Those are the 4 most important symptoms of necrotizing diseases. If you see one of these, chances are you're looking at a necrotizing process. So what are we doing? Usually, not always, but usually at the assessment appointment, we aren't even able to probe. We would have to send the patient home with an antibiotic and some chlorhexidine. Because remember, this is an acidic environment. Is local anesthesia going to work on that tissue? No. So we have to get that pH back to, you know, closer to neutral. And we do that with an antibiotic. We'd also dispense chlorhexidine for them to rinse twice a day. I know y'all haven't watched the recording from last night, but chlorhexidine should be used twice a day for 30 seconds, and we need to wait for at least 30 minutes after brushing. Why do we wait 30 minutes after brushing?
I guess with staining, maybe, I don't know.
Staining, maybe. What does toothpaste usually contain that we want to stay in the mouth for 30 minutes?
Fluoride?
All right, so we need to let the fluoride sit on the teeth for 30 minutes. That's one reason. The second reason is that chlorhexidine can be deactivated or have poor interactions with sodium lauryl sulfate, SLS. Do y'all know what that is? It's the ingredient in toothpaste, soaps that help it foam. It's really not necessary, but it's added, you know, for that squeaky clean feeling. So chlorhexidine doesn't work as well if it's combined with the SLS in toothpaste. So we have to wait about 30 minutes to make sure there's no interaction there. Once the patient's on an antibiotic for about 48 hours, we bring them back. We start our periodontal instrumentation, we reinforce OHI, and then at their next appointment, we complete all periodontal instrumentation. Again, double down on that OHI. The patient really will be compliant because they've been in pain. So make sure we're teaching them how to brush properly. They probably weren't brushing due to pain, how to floss properly, and then what to look for that tells them they need to come back right away. Our OHI, very gentle home care, very gentle brushing. They probably won't be able to tolerate flossing until the periodontium has returned to gingival health. We want to really suggest adequate nutrition and enough rest, avoid exercise and stress, no tobacco, no alcohol. Tobacco and alcohol affect the immune response, and we need their immune response to be at top notch. Again, NSAIDs, chlorhexidine, the patient may need systemic antibiotics. Usually in necrotizing processes, they do. Localized antibiotics are contraindicated. What's a localized antibiotic? We've already learned about.
Arrestin.
Arrestin is not a high enough concentration to kill the bacteria. It's just making it more resistant to antibiotics. So that would be a downside. And then patients may require surgery. This is where patients may need a gingivoplasty to reshape the dental papilla and gingival margins after the cratering experienced in necrotizing diseases. They may also need osseous surgery to remodel the bone or bone grafts, different things, different tissue grafts, but we'll talk about surgery Thursday. So check out this tissue. Isn't that beautiful? It is possible to heal. We can treat and, get some healing here. You can see over here the spontaneous bleeding, the edema. Look at it, looks like saran wrap around the gingiva. It's so full of liquid. But we can return a patient to health. So this isn't hopeless for you or for the patient. Now, maintenance. What do you think is an appropriate recare interval for these patients?
3 months.
3 months, if not less, right? We'd like to see them as regularly, as quickly as possible to make sure that this isn't progressing. So 3 months at minimum. And then we always have to do our reeval. It says 4 to 6 weeks. I would go with 4 weeks for necrotizing just to make sure it hasn't progressed. So we still have time for healing, but we need to make sure that the patient is not reactivating. Now, necrotizing periodontitis, same process, same bacteria involved, except now we're seeing bone loss and attachment loss. You can see that the tissues are fiery red, lots of recession, lots of bone loss. Again, spontaneous bleeding just from manipulating the lip. How do you think this patient's prognosis is just based on what you see from this picture?
Is that ulcers on the lower anterior?
It's just where it actually looks like stomatitis, which is in the next slide, but it's a progression of necrotizing disease past the periodontal structures. What's his prognosis? Excellent, good, fair, poor, or hopeless?
4.
How much attachment do you think we've lost? If we can see here, and the CEJ's here, and there's probably a pocket there too.
Is that more than 4 lost?
Yeah, it's probably more than half of the attachment has been lost. So these teeth are probably hopeless, unfortunately. So necrotizing stomatitis, that's what you're seeing down here, where it's progressed beyond the mucogingival line. We're seeing the lip, the buccal mucosa, the labial mucosa involved, similar symptoms, but this is the most extensive necrotizing disease that we know about. Primary herpetic gingivostomatitis. I just published a podcast on this morning. So if y'all like podcasts, go check out the podcast today. It's about HSV1. This is usually a patient's first exposure to herpes, the herpes virus, and we see severe involvement in the mouth and on the face sometimes. This is very painful and usually occurs in infants and children under 6. This picture right here, this is why you don't let people kiss your baby on the face. You don't know what that patient or what that person has. Even grandma and grandpa or aunts and uncles should not be kissing babies on the face because of this. This is highly contagious. And, you know, imagine having 4 kids and one of them having PHG. How would you keep the other 3 kids from getting it?
It'd be very hard.
You'd have to completely isolate one child and not let the other children play with their toys, you know, sip out of their drink, anything. Yeah, right. If you have toddlers or ever been around toddlers, you know that's not easy.
Can it be transferred by dogs?
I don't know. Can it?
Say, for instance, someone has it and they lick that person and then they come back and
Mm.
lick someone.
I don't know if the virus could survive in the oral cavity of a dog or not. That's an interesting question. I'm gonna have to look that one up. I know that a lot of people, you know, who have oral herpes simplex, you know, it's like 50 to 80% of US adults have this. It's very, very prevalent. It's very common. So, you know, all it takes is for them to kiss a baby during a prodromal phase or something, and the baby can get it. So keep your lips to yourself. Don't be kissing babies. Here's the different stages. We've got prodrome. That's that like tingling sensation they start to feel on their lip, a macule, a papule, and then a vesicle. The vesicle is the worst stage. This is when it's just full of HSV particles that can be spread to other areas of the face. Eventually it ulcers and scabs over. Once we see that scab is when we can treat the patient again. Complete healing, again, we can treat the patient at that point. Vesicles, like we just said, when they rupture, this is why we delay treatment. Who are we worried about with HSV? Who are we worried about transmitting it to during dental hygiene treatment? Ourselves or to the patient?
I mean, can't we make it worse for the patient?
Yes, and that's called an auto infection. So you and I have gloves before we touch the patient, right? Can we get herpetic whitlow if we're wearing gloves? No. But we can move the herpes, you know, virus particles from the lip to the eye or to the skin or, you know, the nose, other areas of the mouth. So this is why you don't treat a patient with an active herpes lesion. Clinical signs, you know, the gingiva gets really, really edematous and erythematous. It's painful. We see lesions surrounded by a red halo, usually a body temperature, malaise, swollen lymph nodes, all kinds of problems involved with this. Can you imagine a 4-year-old having this? It just breaks my heart to know that this happens to kids and they're in so much pain. They can't eat, they don't want to drink, they get dehydrated really easily. So we have to catch this early. Now, if a patient has, you know, just like a cold sore, a fever blister, a oral herpes lesion, we basically give them palliative care, supportive care, keep them comfortable, defer the treatment. We can recommend topical oral anesthetics. There's a lot of over-the-counter products that have antivirals in them, like Abreva. We can also recommend a cyclovir, which is a prescription medication. So let's break down a cyclovir into 3 parts. A cyclovir. What does that mean? A means
Without.
Without, okay. Just gonna do without. Cyclo is cycle. Vir is virus. So without or stop, right? Stop the cycle of the virus. Acyclovir. All right, y'all, we made it. Any questions on this chapter before we start our activities for today? Okay, let's take a break. Okay. Can y'all see that okay? All right, so as we go through, what I want to do is hear your opinions, okay? When we look at the patient profile, does anything stand out to you?
Her age.
Okay, so you said her age. What is a 79-year-old female at risk for?
Osteoporosis.
Good. Osteoporosis.
High
Okay.
blood pressure.
Potentially, yeah. Hypertension. You have not seen this patient in the past. She has visible physical limitations and walks with a cane. She's accompanied by her daughter and her 12-year-old granddaughter. She indicates she has not been to a dentist for 3 years. What does that tell you about her?
She doesn't like the dentist, or she's too busy to take care of it herself.
Good. So for whatever reason, she is non-compliant. We don't know why. We can't make judgments, but she is definitely non-compliant. Her chief complaint: my teeth have not been cleaned in a long time and are in bad shape. So let's see what we can do to take care of that. The patient had a hysterectomy at age 62. What do we know about patients who have a hysterectomy? What happens to their hormones?
They don't make any estrogen. They would have to take it supplement.
Good. They would be on hormone replacement therapy, which can impact their gingival health. She suffered a mild stroke 4 years ago and relies solely on a cane in order to walk, and occasionally suffers with shortness of breath upon exertion. What do we know about a stroke? How does that impact you and I?
May have some paralysis on the left side.
Okay,
She's unable to brush her teeth.
good. Paralysis and how it relates to her OHI. Very nice. She recently underwent laser surgery on the retina in her right eye. She indicates she gives herself insulin injections daily and reports that her HbA1c values are typically between 8 and 9. What does that tell you? 8 and 9. Is that well-controlled diabetes?
No, it's not a control.
So it's poorly controlled. Now, we don't have any other information yet, but if she's giving herself insulin injections, which type of diabetes do you think she has? Insulin. Type 1. We don't know for sure, but that's, our best guess based on this medical history that we have. So she has comorbidities, including diabetes. Does that put her at higher risk for periodontitis? Yep, especially with her uncontrolled diabetes. GERD, what is GERD?
GI.
Acid reflux.
Yeah, it's like acid reflux, GI issues, hypertension, hyperglycemia, and ding, 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 osteoporosis. So what is this patient's risk for periodontitis? Low, normal, or high? Super high. Okay, good. Anything about the medications that you want to talk about?
It could cause dry mouth, some of her medications that she's taking.
Okay, so Prilosec, definitely. That's for her GERD. She's taking aspirin every day. What is that telling us? What do we have to look out for?
Could be ulcers.
Potentially ulcers, and then also increased bleeding, right? Because it's an antiplatelet. Yes. What else? What do we know about statin drugs? What are those?
Is that for your cholesterol?
Cholesterol. So she didn't report her cholesterol on her medical history, right, as a comorbidity, but she's taking a medication for it. So that's something that we would need to ask her about. Atenolol, what are the olols?
Blood pressure medicine.
Okay. And then Plavix. What is Plavix?
Blood thinner.
For stroke.
Yeah, so she's taking Plavix and daily aspirin. We really have a problem here. So her bleeding is probably going to be off the charts. All right. I skipped one. What is, I don't know this one, ramipril. It's an ACE inhibitor, April, an ACE inhibitor. Okay, so another one for hypertension. She's on a lot of medications. Okay, and then Actonel is our next one. Okay, Actonel is for osteoporosis. So that's a weird one for osteoporosis. Okay, HbA1c again is 8 to 9. Her vital signs, how do our vitals look? How's the blood pressure?
Normal.
Is it normal? Does that 80 push her into elevated?
Mm-hmm.
Once we get to 80, we're at elevated for blood pressure. Okay, respiration at 20 breaths per minute. How's that?
Kind of high.
Yeah, it's at the very edge of normal. 20 is at the very edge. Once we get to 22, we're into hypertension. I'm sorry, hyperventilation. Okay, she had the mandibular right first molar extracted 4 years ago and has received no dental treatment since. She brushes her teeth twice a day with a fairly hard manual toothbrush. What do you expect to see from that point? A fairly hard manual toothbrush.
Recession.
Recession, good. She does not floss and uncertain whether she uses a fluoridated toothpaste. She's curious about a power brush since her hands are weak, and she has questions about whether a mouth rinse will reduce the bleeding from her gums. Extra oral examination, we see a large nevus. What is that?
It's a birthmark on her face.
A nevus is generally raised. So if it's a birthmark that's raised, what's the common term for it? It's a mole. A nevus is a mole. All other assessments are within normal limits. Intraoral examination, large circular discoloration above number 10 and 11. Bleeding index is 55, plaque score is 65. Those are pretty high. Okay, let's look at her x-rays next. Are you noticing anything on the x-rays of importance? Let's start here.
There's a lot of calculus.
There is a lot of subgingival radiographic calculus. We've got retained wisdom teeth. What are we seeing here? Guess it's not really cone cut, but if it was a digital set, that would be considered cone cut, right? It's just they mounted poorly. What else?
She's got bone loss.
Definitely some bone loss. Good. So I'm glad you mentioned that here. She wasn't biting all the way on this bite wing. Okay, let's look at her intraoral pictures. What are we seeing here?
She has a lot of staining.
A lot of staining. Moana, I saw you say it.
She has mandibular tori.
Mandibular tori here. Good. Anything of note here?
She has visual calculus on the lower anteriors.
How's our gingiva here?
Yeah, she has
Rolled.
Yeah, rolled, erythematous, edematous. What do you think we might see on the ventral surface of her tongue, just based from right here? Those are lingual varicosities. Remember, lingual varicosities are those deep purple or blue veins that run up the ventral side of the tongue. Let's see, is there anything else? Yes. How would you describe this lesion above 10 and 11?
Melanin pigmentation.
Okay, could definitely be melanin pigmentation. It's flat, therefore it's a macule. It's got kind of a brown color to it. And then I want you to notice the spacing between her anterior teeth. She doesn't have contact between the anterior teeth from this angle. So a lot of diastemas, a lot of blunted papillae.
Her bite is edge to edge.
Yep, edge to edge, very good. So we have a lot of stuff going on for this patient. She really needs our help. What do you see here, this white lesion? Kind of goes all the way back here.
Is that linear alba?
Yeah, it's linea alba. And then how would you describe these red marks?
Is that like it's petechia or petechia?
Yeah, exactly. Petechiae, where she's been biting her cheeks. So clearly there's something going on here. She's either clenching or bruxing, something to cause this trauma on her buccal mucosa. Okay. Next, we have her perio chart. How are we looking here? I see lots of bleeding.
She doesn't
Lots of
really-
4s and a couple 5s.
Okay. Definitely have some recession going on, up to 2 millimeters of recession.
It's mainly
So-
in the maxillary area that she's got problems versus the mandibular.
Okay. So based on this perio chart, what is your AAP stage? Remember, we go by the worst area. So what's your stage?
I'm gonna say stage 2.
Stage 2, anybody else? How do we determine stage based on a perio chart?
Pocket depth and attachment loss.
Okay. What is our deepest pocket depth throughout the mouth?
5.
5. And that would put us at a stage what? Well, let's talk about,
Okay.
are the 5 mm pockets generalized or localized?
Localized.
Yep. Let's see. Let's see. Yeah, I would say they're localized. We don't have enough to say it's generalized because look at all these, just 3 mm, right? 4 mm. So we have greatest site of attachment loss is 2 mm with localized 5 mm pockets. I've got some people saying stage 2, some people saying stage 3. What are we thinking as a group?
Well, I mean, I guess it could be stage 2 because it can be greater, I mean, less than or equal to 5 mm pockets.
Okay, but remember that has to be generalized, right? That would have to be generalized 5 mm pockets. Do we have generalized pockets? No. So we have to go off the site of greatest loss, and that is what? Two. So what stage has 1 to 2 mm of clinical attachment loss? Stage. Staging starts at the beginning of periodontitis, right?
Stage 1.
Yes, so it'd be a stage 1 for this patient, stage 1. Good. Okay, let's go to some questions. Whoops. I'm gonna skip the ones that aren't about perio so that y'all can, you can look at the key later, but let's talk about the perio questions. All of the following are home care regimens that would prove beneficial for this patient except one, which is the exception.
Sodium fluoride.
Okay, so we've got to vote for sodium fluoride.
Phenol mouthwash, mouth rinse.
A phenol, where do you? A phenol, there's chlorhexidine. You think she doesn't need chlorhexidine? What do y'all think?
I also think it's C.
Sodium fluoride, okay.
Yeah, sorry. See,
It's okay. I was like, I don't see a phenol, but I'll take it. Okay, why sodium fluoride? Why do y'all think that?
Her blood pressure.
Ah, I see where you're going with that. So she's not actually going to swallow it, but sodium fluoride is usually for anti-caries. Did she have a lot of caries on her chart? No. So she does not need sodium fluoride dentifrice. Good. Okay. The brown circular discoloration above number 10 and 11 is most likely a
Melanin pigmentation.
Anybody disagree? You are correct. It is melanin pigmentation. Let's see. Based on this patient's clinical and radiographic findings, how would you classify her periodontal status according to the 2018 AAP classification? So let's think back. Her A1C was at least 8. What does that tell you about her grade?
It's a C.
It has to be a C, right? They have this one incorrect. What did we say the stage would be?
1.
Yeah, so she'd be a 1C. This answer is wrong. They don't have the right option. It's saying that the answer is B, which can't be correct because we know her diabetes is uncontrolled. Okay. Oops, I didn't even fill it out. My bad. I got them all wrong. Ugh. Okay, so I want you guys to, go through that, use these as practices for your board exam. And does anyone have questions before we move on? Did it help to go through the case study step by step and like point out what's important, what you need to be looking for? Okay. All right, I'm gonna end the recording